Okay.
You can see me, Mohammed, isn't so?
Yes. So we'll
connection.
We will let's see who's not here yet. So Ayman, by the way, where did you go in Saudi Arabia? Which hospital again? Which hospital was it? Because we have Dr. Ayman, you hear me?
Yeah,
Who?
now I can hear you.
Yeah, we do have, I think, visitors from King Faisal, Dr. Ayman. So I don't, you were there or no?
Yeah, King Faisal I was.
Okay, so I'm not sure whether they are there. I think because I think there is. So I mean, people from King Faisal, welcome, and feel free to unmute yourself and speak up if you're willing. Okay, but I believe there is at least a couple of them. Okay, I invited them. Amen. I don't know whether you know them, but they are fellows. So maybe
names you have fellows. Maybe new.
Well, I think fellows are coming. I don't know whether the staff would be attending as well. But anyways, but you know, not many people from our hospital yet. So I don't know. I know it's tomorrow's Eid, so maybe that's why. But
yeah.
Muhammad Mitwalli is not there. He's the main one. Usually he's the one who's arranging everything.
What happened to him?
I don't know. Okay. I think it's 9:06. We should probably start, right?
Yes, because we need to go. I have an appointment at 10:30. Huh?
Yeah. Okay.
Okay. Supermarket.
How do you get appointment supermarket? I tried. I couldn't get.
You can. You use the website. I'll send you, Dr. Babu.
Okay. Please send me.
Of course.
Okay. So welcome everyone. So you know, yeah, we did already speak about previously. We did speak about regular ECG approach, and then we talked about SVT. If you guys remember, for the past 4 or 5 weeks, we did like an hour and a half per week roughly. So for those who are new, we already had SVT talk, and we already had ECG, normal ECG stuff. So then I was asked to just practice more ECG stuff before changing the subject. Okay, so this is what will be about today. It's ECG examples of specific arrhythmias. Okay, so Mohammed Wali is here, so welcome Mohammed Wali. Okay, so since it's ECG examples, it would be more interactive than usual. I mean, it's always interactive, but this time would be even more. So if you are in a place where it's not very loud, please unmute yourself and speak up, because I will show an ECG and one volunteer, at least 1 or 2 volunteers speak up and see what you think and blah blah blah, and then we'll discuss it as a group. Okay. So especially for King Faisal fellows, if you guys are if you don't mind, you can unmute yourself and please be interactive. Okay. So this is the first ECG. These are all our patients recent, the past 2 years, since I joined, over the past year and a half. And this patient was in fact one of my first consults that I had. This ECG was taken on September 10th, 2018, and I joined September 4th or something, so it's almost one of my first consults. And it was very nice ECG. So any takers, whoever is interested, please speak up. I know everyone is unmuting himself. For example, Ahmed Nabil, I see Ali Sharaf, those who I know, Mervet, Muhammad Mitwalli, Muhammad Taha, Nasser, if you can speak up. And I'm not sure who else, and whoever from Saudi Arabia as well, please. Anyone speak up so that we move quick.
No takers?
Babu, I don't know, it's up to you guys. Someone has to speak up.
Yeah, let others do. I will do last.
Okay, so I'm waiting for others. The problem is no one is. saying anything.
Okay, then I will vote for atrial tachycardia, ectopic atrial tachycardia, or a jet, I think.
Okay, so Babu, you will take this case, right? Okay, good. So why do you say that? I mean, I cannot. You can't see my pointer, right? Right?
Yeah, I can.
Yeah.
I can.
Okay. So unfortunately, I wish there's a way I can see your pointer, but I don't think it's possible. That's fine. Okay. So Babu, why do you say atrial tachycardia?
Because I am seeing P waves,
Yeah.
something like a P wave,
Right.
particularly if a rhythm strip lead 2,
Okay.
and the PR interval varies.
Okay. So, okay. So, so your vote is atrial tachycardia. Anyone else disagree or agree?
Frequent BVCs.
Okay. Ayman is saying frequent PVC.
And
okay.
I will say there's a irregularity, and the P wave morphology is different. So I would like to go multifocal atrial tachycardia versus flutter, versus fibrillation.
Okay. I'm guessing you are from Saudi Arabia, right, sir?
Yeah, King Faisal Specialist Hospital.
Yes. Welcome. What's your name?
Walid Al Harkan.
Walid. Okay. Thank you, Walid. Okay. Okay. Anyone else? Okay. So I heard PVCs, I heard atrial tachycardia, AFib, multifocal tachycardia, right? Okay. Jet. I heard jet as well. Okay. Okay. So again, it was very, it was, it's a confusing ECG, but if you, I'm sorry. Yes, it's a confusing ECG, but if you relax and slowly look at it, it's very easy. Okay, so first is, this is how I approach this ECG. You see this ECG, it's very irregular, messy, multiple QRS complexes, different morphology QRS complexes that you see. So start with what's easy and obvious and you're definite about. So you see P wave here, P wave, there's an artifact, P wave here, P wave here, P wave here, P wave here. And then, this is again a couple of weeks old. So it's a baby who was asymptomatic, came for echo because of irregular beats, by the way. And, you see a, normalish PR for a baby. And then you see, so I will say this is probably a sinus P wave with a normal PR interval and normal conduction, okay? And it's narrow QRS, okay? And then I follow this, okay? I see PQRS, P, and then T, of course. PQRS, T, PQRS, T. PQRS is a little bit different than this QRS, right? And then T. PQRS, similar to this QRS, but different than this QRS, and then, T. And then P, super short PR with a wide QRS, right? And then this repeats itself. You see P, PR, QRS, T, P, PR, QRS, T, P, PR, QRS, T, so forth. And then suddenly you see P with very short PR with wide QRS. And then you don't see P, or you may see the beginning of the P, but the QRS is almost on top of the P. And it's a wide QRS, right? Do you guys follow my,
Yeah.
Yes.
Yes.
Actually, I have animations here. So these are my P waves, and then these are the P waves, and then you see PR super short, and then PR almost non-existent, right? And then what else do you see? If you move forward, you see P after the QRS here, right? So if you zoom in, if you march, these are lines on the P wave. So you see P, QRS, P, QRS, P, 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 P. And then you see the P's are, this P is hidden in the QRS, and this P is after the QRS, okay? So, knowing all this, do you still vote for atrial tachycardia? Is it possible for atrial tachycardia to have such a phenomenon? Is it possible for atrial tachycardia, to have a
Regular.
P that is after the QRS?
No.
That will be AV dissociation.
Right, but they are, the QRS rate here is faster than the PP rate. Eventually, so the the P, eventually the QRS rate, if you see my hand, is approaching the P and then, going ahead of the P. So you have ventricular rate faster than an atrial rate. This ventricular rate, which is 200 beats per minute, is faster than the PP rate, which is a little bit slower. Okay. So this cannot be an atrial tachycardia. In atrial tachycardia, your A's are faster than your V's, right? Because it's atrial tachycardia.
Okay.
Right? So this definitely is not atrial tachycardia. If you see AV dissociation, this is the term, when you see the P waves are marching through without relation to the QRS, and the QRS are just doing their own thing, whether it's slow or fast, unrelated to the P wave, the atrial activity. So this is AV dissociation. When you have AV dissociation, you could have it in complete heart block when you're very, you have very slow QRSs, or you can have it in, tachycardia, some tachycardias where you have AV dissociation, but with a fast, ventricular rate. Okay, so in this case, you have AV dissociation with a fast ventricular rate, and the QRSs are different than your sinus QRSs. Like this is your sinus QRS, right? This is your nice narrow sinus QRS, and then of course definitely wider QRS. It's not super wide, but it's big, you remember. So this is wide.
So it's a VT, huh?
Right. So that's that's VT. Okay. Of course, and then you wonder, why do you see a QRS morphology that's in between the wide QRS and the narrow? You see something in between.
So that's the fusion beats and capital beats.
So these are fusion beats. So meaning
beats.
Yeah, meaning you have a sinus beat here, and then it was conducting down the normal, conduction down the AV node, but there was a PVC that happened at the same time. So you get a fusion between the PVC and the normal, QRS. So then you get a, a fusion or a beat that is in between the super wide beat or the pure VT beat and a beat that is, and in between the normal sinus beat. Make sense?
Those are the 4 consecutive ones? Fusion beats.
These two.
Yeah, in the beginning of the tracing, beginning of the rhythm stream.
You see my line, my red mark? Yeah. Look, it's wider than the normal beat and narrower than the, VT beat. So this is fusion.
Okay.
The beat that is fused. So meaning if I let me draw the heart for you here. So, you have a sinus beat that came in, okay, and a PVC that happened at the same time. So you have a fusion between a PVC and a sinus beat. So you have a QRS that is in between the VT and the sinus QRS, okay? So this is classical of, ventricular tachycardia, okay? This is classical, typical ventricular tachycardia. And this patient actually, Dr. Babu, he was your patient, and you also thought it was atrial tachycardia back then. And we discussed it. But anyways.
But let me, only one question I want to ask you. We generally think VT is quite regular tachycardia, isn't so?
Well, no, if you look at here, you see it speeds up,
It's an irregular tachycardia.
Right, irregular, it's bursty, meaning it stops and starts, It warm up, meaning it starts slower, then slowly speeds up, and irregular. So this is, automatic, form. Remember we talked about reentrant arrhythmias and automatic arrhythmias. This is an automatic arrhythmia where it starts and stops all the time and has a regular heart, regular cycle length and rate, and usually starts slower and then speeds up. Okay, like in this case, you see slower here and then speeds up here. Okay.
But if you look at the in a rhythm strip, after the 5th beat, there's a long pause there.
Yeah, this long pause is because this VT beat when there was a retrograde P wave that resetted the sinus beat. So imagine you have a PVC, the focus is here. It went upward through the AV node all the way to the SA node, and then you get something called sinus node reset. That's why. So eventually,
sorry.
Yes.
Sorry, Mohammed, can you repeat the last bit? Because in the 1 minute I have a poor connection.
Okay.
I changed my position because of this.
Right. So
just the last thing.
Yes.
This is a fusion beats, right? You show the fusion beats.
No. So when you have AV dissociation, usually it's dissociated because they are almost at the same rate. But when the VT is very fast, you can hear me, Ayman? Hello? You hear me?
Ayman probably has disappeared.
Oh, he disappeared? No, yeah, I don't know.
Sorry.
Yes, Ayman, you hear me?
No, I'm fine, yeah.
Okay.
I changed my position.
Okay, so the ventricular rate, if it's very fast, it eventually goes up the AV node and all the way to the SA node and resets the SA node. Like you eventually will have association between the ventricular and the atria if the ventricular rate is very fast and you have a normal AV node, because because imagine you're the heart, the heart is here, right? You have, of course, the SA node is normal, will keep firing unless you are very faster than it, such that there is the time between the focus of the ventricle up the AV node all the way to the SA node is super fast. Then the SA node will not do anything. So then you'll have association, meaning you have one-to-one retrograde P's. So this is what was happening here. It eventually sped up such that it engaged the atria retrogradely, and then the SA node would not do anything. And then when it stops, the SA node takes a minute to resume, and this is called sinus reset. Okay, sinus node reset. Okay.
Oh, okay.
When it's not very fast, you get competing P's and V's, but they are not, the V is not fast enough to take over. So then you have AV dissociation or VA dissociation. Okay.
Good.
So that's why, Dr. Babu, here you have dissociation, because it's not very fast for a baby. Like the sinus rate is 150, 170, and the VT rate is 190, 190. Okay. Okay. So, Dr. Waleed, did you understand me?
Yeah. Yes, I got it. But if I'd like to ask about the origin, could we suggest that this is from the LVOT in this picture, as the direction of the ABF is downward, so origin from superior, and there is left bundle branch block, so from right ventricle. So can we say from RVOT origin?
Yes, you can. I mean, you're getting this is more advanced, but sure, yes. So it's probably outflow tract origin. That's probably right ventricular, RVOT origin. You're right.
Because the LBBB type of
because
complex.
left on the branch block morphology, and you have axis of the VT that is going inferior. Okay. Okay. So
axis of what? Axis of what is going inferior?
The VT.
The QRS.
Inferior.
QRS axis.
The VT, yes. Okay. So it's you have positive 2, 3, and AVF.
Yeah.
So this is okay. So that's more advanced because he's not at an ablation age. He's only a couple of weeks old. So we typically, of course, this is not usually people don't ablate this. It's usually benign 4 to 6 months and goes away. You have to, of course, treat it aggressively initially because it's a little bit difficult to treat. In his case,
this is the one you started beta blocker, isn't it?
Yes, we started beta blocker, and he did very well with beta blockers only, but high dose. If it's VT, you aim for a beta blocker dose of 3 to 4 per kilo per day, rather than your typical 2 per kilo per day, SVT dose. Okay. So,
specific beta blocker or selective or propranolol?
No, any beta blocker, but I usually do propranolol at this stage. Okay, because propranolol is short acting. If something bad happens, it's short acting. Then you easily could reverse it. And it's very known and safe for for newborns. It has been used for many years. And hypoglycemia is an issue, but of course
not much if you use it.
Yeah, but that's why you started in house. But then besides hypoglycemia, usually nothing major happens. Okay, if it's an appropriate dose. Okay.
Sure, doctor, I have a question, please.
Yes.
Doctor, this is narrow complex. What we know usually the ventricular tachycardia is wide complex. Why it is narrow here?
Well, remember he's a baby, newborn, okay? And this beat, this is your sinus QRS. You see it? This is what's normal for. Let me erase things so that you can see it. Okay, you see this beat?
Yes.
You can see this is around 40, 60 milliseconds.
It's normal sinus.
Yeah, normal. But this VT beat for a baby, definition of wide QRS for a baby is above 80, 90 milliseconds. That's it. Okay. So this is definitely wider than your sinus beat, right? So that's wide complex. Okay. That's a common, pediatrics, of course, babies, their wide QRS is almost normal. Okay. So as long as
wide QRS difference more than 2 divisions, isn't it so?
I'm sorry?
Wide QRS in babies is just 2 divisions.
Yeah, 80 milliseconds and above 90 milliseconds. This is wide. Okay.
Okay.
But in this case, the baby the baby is giving you a hint. He's telling you this is my usual QRS. Okay. So you can cheat. And then why you have a different QRS that's super wide for him, okay? So that's wide QRS tachycardia. That's either aberrant conduction or VT or junctional tachycardia with aberrance. You cannot call this narrow QRS, okay?
So you are saying it's not aberrant because there is no PQRS relationship.
Yes, so it's not aberrant because there's VA dissociation. When you have a VA dissociation, there's no aberrancy involved. Like, aberrancy means you're going down from A to V with aberrant conduction, okay? So there is a relationship during aberrancy. There is an association between the A and the V, okay? Of course, you may have junctional aberrancy, which is, more complex, but let's skip junctional aberrancy. But your typical, SVT aberrancy, it's you have an A goes down to the V with an aberrant conduction within the V, okay? So you have association between A and V, okay? Okay.
One more thing I learned out of this is, Mohammed, usually I thought capture beat is only one beat and fusion beat is only one beat. I never seen a series of capture beats and series of fusion beats.
Oh yeah, there's no set rule. It may happen once, may happen 100 times. There's no set rule.
Yeah, here too many PQRS like going on.
Very beautiful ECG, very beautiful ECG. Okay, that's a textbook, exam, teaching, nice teaching ECG. Okay, and it's from our, one of our Euro patients. Okay, so thank you for sharing this patient. Okay.
Okay, good, thank you.
Okay. Any other questions? So here we said burst, irregular warm up, wide QRS, onset with the QRS. So again.
So ventricular tachycardia can also have this warm up phenomena.
Yeah, all automatic tachycardias.
Okay.
All of them. Okay. So we said all this. Okay. So I'll move on. Okay.
Yeah.
Okay. Good. I like, folks from Saudi Arabia, you are active. That's good. Our people are quiet today. So, okay. So another patient, 32 hours old. Okay. This patient was like we got this patient like 6 months ago. So also fresh patient, 32 hours old. They called me from a private hospital saying that his heart rate is, 180 at least, and when he's crying all the way to 220, they're not very sure whether it's sinus tachycardia or not. They gave adenosine, and nothing happens, and he's a stable, child with normal echo. Okay, and this is the ECG. So any takers?
Yes.
Yes. Who's this, Dr. Walid?
Yes, someone.
Okay, please go ahead.
Okay, thank you. We can say this is a narrow complex tachycardia, and we couldn't see a clear P wave, and so we have a differential. I couldn't judge about the P duration. Is it long or narrow from this, because I couldn't see clear P wave. But we need, according to the history that adenosine given and no change happen, we can rule out AVRT, and even AVNRT, as this age is not the typical age for AVNRT. So I will go with the flutter. I will do ECG during the adenosine, and they will see how is the rhythm. Is it flutter type or not?
Okay. So your vote is flutter. Okay. So why do you say flutter specifically? Because the adenosine didn't work. That's your main reason, right?
Yes.
Okay. Anyone else agree or disagree?
In lead 2, I can see something like a P wave superimposed over T.
Okay. In
lead 2 and lead 3.
Okay. So can you tell me which beat?
Yeah. If you, I don't know how to show to you, but you can move it up, move your pointer up.
Yeah.
To the left. That's one.
This one. Okay.
Yeah.
So you think there's a P wave here? Okay.
Yeah.
And there's a P wave here.
And there also.
Okay.
Next one also you can see.
Okay. You think there's something here. Okay. And then you think there's something here?
I don't know. I'm not very sure there.
You think there's something here? You think there's something here?
No, the first 2 beats might be.
So if you look at, I think it's a long RP tachycardia.
Okay. So, okay, I heard flutter. I have long RP tachycardia, which means atrial tachycardia or atypical AVNRT or PVRT. Okay.
Atypical AVNRT then, isn't it so?
Well, anyone else? You know, remember AVNRT at this age is very unusual.
Yeah, you taught us that. Yeah.
Okay, anyone else? Okay, so I will, if no one is speaking. So, you know, I'm glad that I'm showing these ECGs because, you know, obviously they are challenging, but they are also very nice and must know ECGs, okay? Okay.
The other is probably flutter to 1:1, flutter. Is another differential probably I will consider.
So flutter flutter 1:1 is usually very fast. You know, usually 100 beats per minute. You know, 350 beats per minute is very fast. This is not super. This is not a flutter rate for 1:1 conduction. Okay. If it's 1:1 conduction, then maybe. But
if 300 or more.
Yeah, but I'm telling you, his heart rate is varying. I told you when he's crying, it's 220 to 18. When he's sleeping, it's 180. So there is variation in heart rate, which is against flutter, right, Dr. Walid? Dr. Walid, flutter is typically steady rate. If it's 1:1, it's 350. If it's 2:1, you know, 180, okay, or 200, okay, 180, okay.
Okay.
So very unusual to have, you know, flutter that is varying in conduction. And sorry, in ventricular rate, unless you have a diseased AV node. But you know, he's a baby with normal heart. His AV node is perfect. Okay, okay. So, okay. So you know when you.
So you think it's a atrial tachycardia?
Well, wait. So, of course, one of the differentials. But when you see a QR, when you see such ECG, you know it's something fast. You know it's something abnormal. Your first to-do list or to do something is to hunt for the P waves, right? And then the question is, where are the P waves? So like Dr. Babu is saying, you know, difficult to say, maybe there's a P, maybe there's not P here, there. But if you look very, very, very carefully, you see there is something here, right? Okay.
Where your pointer, where is your pointer? Oh yeah, there.
You don't see it? Okay. You see, and then if you look very carefully, you know, you see something here, okay? You see something here, okay?
WBW?
Well, wait, you see something here, you see something here, you see something here. Everyone agrees that there is this, you know, so again, P waves are, someone with a bird, please unmute yourself. So P waves are small, sharp deflections, okay? Everyone agree there is this deflection here is not definite, is not a T wave, right? You see it here? Do you see my markers very well?
Yeah.
Yeah. So you see this QRS, there's this deflection that is here is not here, right? So if you compare this QRS with this QRS, there is some deflection here that is not here, right? Everyone agrees?
Yeah.
You see there's deflection here, but it's not here, right?
Yeah.
So
AV dissociation.
Right. So this is AV dissociation again. Okay. So there are P waves that are marching through, and they are slower than the ventricular rate, and they're, you know, this is a beautiful AV dissociation. Of course, not very.
So it's a VT, yeah.
Well, when you have AV dissociation, then your differential is what? You tell me. So what's your differential if you have AV dissociation? It could be VT.
Functional.
Okay. It could be VT. Could be junctional tachycardia.
Functional.
Okay. So if you have tachycardia with AV dissociation, it's either VT or GT. Okay.
So Mohammed, can you say jet then?
Well, you can. So it's a differential now, right?
Yeah.
So with jet, what the QRS would be narrow, like normal, and with a normal axis. You see the axis here. You have left.
Yeah, this axis is the right superior quadrant axis.
Right. So you have you know, north axis, and you know, I know someone said narrow. Dr. Walid said narrow QRS, but it's not very narrow. It's at least 80 milliseconds QRS. Okay. Again, for babies, you know, folks from Saudi Arabia, you know, newborns, you know, the usual QRS is super narrow. Should be 60 milliseconds, 50 minutes, very narrow. Okay. I mean, train your eyes for babies. You know, this QRS is wide to me. This is, you know, this is not, let's say you have a sinus QRS with such a wide QRS. This is not normal for a baby, okay? So the definition of wide QRS for newborns is different than a 7 years old, okay? So axis is off, axis left axis. You see AVR is positive, which is very unusual you know, AVR, almost always AVR is negative, okay? If you see AVR positive, that could be, of course, you should think of VT. You should think something else because, you know, if you have junctional tachycardia, like this is one of our differential, right?
Yeah.
A normal heart, you know, again, I'm telling you, echo is perfectly normal, okay? You would expect the ventricular, you know, the QRS axis to be normal, okay?
Yeah.
It's jet, it's coming from the AV node, it's like sinus tachycardia, okay? But in this case, the axis is completely off, okay? It's going upward, okay? With a positive AVR, and you have AV dissociation. So this is VT until proven otherwise, okay?
So you think it's a VT?
Yeah, it's definitely VT, okay? So it's another VT case. So, you know, when they gave it, I went to, you know, this was a patient, you know, relative of a physician. So I actually went to this private hospital and I did adenosine myself. And, you know, with, you know, sometimes with junctional tachycardia, if you give adenosine, you may have brief termination because it's an AV node tissue. But in this case, there's any brief termination. It's just the PWA, you lose, nothing happens. You know, there's AV dissociation, and you know, AV dissociation remains. You know, if purely nothing happens. You give him high dose of adenosine, definitely nothing happens. Okay, good dose, good flush. You know, big IV line, everything. So this is, you know, VT. Okay?
So the origin probably is on the left ventricle now here, isn't so?
Yeah, so the origin is leftward because it's, you know, it's
yeah.
right on
it's
the,
a RBBB. No, this is RV.
Yeah, but not superior. You know, somewhere down. Okay, somewhere within
Yeah.
the ventricle body. Okay, so
Yeah.
you know,
Yeah.
so this is another easy. You know, again, you know, it's not very fast. The baby is actually doing very well. It was doing very well. You know, because it's not very fast. And you know, VT in babies is very well tolerated in general. Okay. You know, every now and then you may get super fast VT, then of course not tolerable. But
So did you treat this baby?
yeah, we gave him beta blockers as well. You know, we gave him high dose beta blockers, 4 per kilo, and you know, super perfect halter on. And I just stopped his medications just last week, because he was almost 6 months late now. Okay, so okay, so Dr. Walid, you agree? You see the V8 association. You have to train your eyes about the V8 association.
Yes, sure.
Train your eyes about, you know, whether it's narrow or wide QRS for a newborn. Okay, that's, you know, there's definitely, you should never see a QRS that's fractionated like this and it's normal. You know, if you see fractionated QRSs like these, you know, there is interconduction delay. There is interventricular conduction delay. Okay, that's not normal conduction for a baby or for anyone else, for anyone. Okay.
Yes.
Okay. Anyone else? So I know many people are quiet. So everyone is happy. The rest who are muting.
I'm muting because of the bird. Anyway, my question is about the QRS.
Yeah.
I see it not that much wide. So you are
he's a newborn. You know, he's only 32 hours old. You know, QRS for a baby is usually, you know, 60 milliseconds. Okay, by definition, the cutoff is, you know, depending on where you read, your cutoff usually 80 or 90 milliseconds. In this case, if you look carefully, I mean, I have to zoom in. It's around, you know, definitely at least 80 milliseconds. Okay? So it's borderline. So it's definitely on the wider side. Okay.
Okay.
And then again, you see many newborn ECGs. You know, you don't see fractionated QRSs. That's not normal. Okay. When you see fractionation, you know there is slowing of conduction. It's not through the normal His-Purkinje system. Okay. You know, you see this.
And how about you judge about the axis? The axis is northwest, higher up.
Yeah.
So you said from down is going the signal.
Yeah, it's going from down up. Yes.
Okay. Down up, huh?
Yes. So that's not sinus or not SVT
not sinus
with aberrancy. You know, in a normal heart. Okay. Of course, you know, with aberrancy, if you have left bundle branch aberrancy, you may get an upside down axis, but you need to have a left bundle branch block usually. Okay. Okay.
Okay.
Okay. Any rest? You know, chest hospital, please speak up. Okay. No one wants to speak up. Okay. Okay. So we said, you know, unresponsive adenosine irregular. Well, I mean irregular, not in this ECG. I'm telling you the history. It was irregular. Okay. Axis is against aberrancy. Positive AVR. This is VT. You know, definite VT. Okay. Okay.
Yeah.
Okay. again, treatment was beta. Of course, often you need something else, but I was lucky. Beta blocker was more than enough for him. Okay, but we needed
for how long?
4 months. But in his case, when he went, I know he needed at least 4 per kilo. If you go down, he had relapses. So in fact, at some point we readmitted him because he was fattening up, and dose was around 2 per kilo, and he had so much VT. So I upped the dose, and it's magic. He was really nice. It was really responsive beta blockers, but just needs a high dose beta blocker. Okay. Another one here. So the history is 3.5 years old. Again, this is a patient who came in when I was, exactly last summer, like last July, and I wasn't, I was traveling, and I don't forget who was it. Maybe I think Ali or someone called me with this ECG. So 3.5 years old, normal heart, echo-wise, palpitations. If I remember, I don't remember the history very well, but I think just palpitations. And then, this is his ECG. Okay. So any takers?
Yes.
Yes.
In this case, we have Maha from King Faisal.
Yes, Maha, welcome. Yes.
In this, we have wide complex tachycardia.
Okay, thank you.
Tachycardia. We have superior axis.
Yeah.
And we have positive AVR. QRS is positive, and complete dissociation between AV dissociation. So this most likely be TAC.
Okay, why do you see complete AV dissociation? Where do you see P waves? Can you guide me where is the P wave? Like which lead you're looking at and stuff?
No P wave seen.
Yeah, Meha,
we have
where? Tell me.
In V2 it is clear. There is B wave.
Do you think in lead 1, the second beat?
And
lead
also
1.
in lead 1.
Okay, so
second beat.
In lead 1 you're saying,
lead
right?
2.
Yeah.
Lead 2 also.
Go to the the second beat.
Yeah.
Second beat.
Yeah, so the question is, of course, so again we should hunt for P waves. In this case, it's really difficult to convince yourself there are P waves. Of course, if you look carefully, you wonder, is this a P wave?
Yeah.
Is this a P wave? I don't know, to be honest. The
next one.
Last examples were, to me, I can swear P waves. The one I highlight, I swear these are P waves. In this case, maybe I cannot swear, but maybe. Okay, but definitely difficult to see P waves. Okay. But
yeah,
what's a given? What's a given? What's this thing that we all agree with? It's definitely white QRS, and the axis is off. You have again superior axis. Okay, you have positive AVR. Okay, so this suggests
what is an AVR, Mohammed?
Positive QRS.
Huh?
Positive QRS.
Oh, positive QRS. Yeah. Okay.
So, again, AVR is all the way here. It's difficult for an aberrancy. If something supraventricular is usually AVR definitely negative. AVR is it's a good lead when you're not sure whether it's VT or not. Okay, AVR is an ignored lead. No one looks at AVR, but if you wanna, you have to look at AVR because it helps you in such scenarios. Okay, you're not sure is it VT, is it aberrancy? Look at AVR. Okay. Okay.
So you look at AVR regarding the P wave or the QRS?
No, QRS. I'm talking about, I'm not very sure I see P waves clearly. Okay.
Mohammed, AVR in aberrancy will be negative, huh?
Often, yes, negative. Of course, if you have a normal heart, Babu, I'm not talking about hypoplast or Dextrocardia and all these things. I'm talking about normal heart. Okay. Yeah. So normal heart AVR is almost always negative in SVT.
All the waves are usually negative.
In AVR, yes.
Yeah.
Okay. So I think there is AV dissociation, and I think there are P waves that are marching through, but I cannot swear, but I can swear there is definitely left axis deviation. There's definitely positive AVR. It's definitely very wide. Okay, very wide. So you can give adenosine in this. So I'm asking you a question. Would you give adenosine because you're not very sure? Because this could be, aberrancy, maybe, but again, very unusual. Adenosine usually doesn't hurt so much, except, you have contraindication for adenosine. I don't know whether, do you guys know what's contraindication for adenosine? Definite contraindication? Like, you should not give adenosine in what case? Like, it's a
you said you said WPW with the AF.
Right. So that's one.
AF with WPW.
Yes. So do you think this is AF? I don't think this is AF because very regular.
No, it is. It is not irregular.
Yeah. Okay. What else? There's something else that you should not give adenosine that we don't usually see because
you said ectopic atrial tachycardia.
No. I mean contraindication, meaning something bad may happen. With tachycardia, usually nothing. It's a waste of your time. Okay. But then, something bad may happen. So when you have a transplant patient, okay, so
cardiac transplantation,
you don't give adenosine. The teaching is don't give it because they are very responsive to adenosine. You may have a very prolonged period of asystole. Okay. So of course he's not transplanted. Anyways, so you can give adenosine. I wouldn't give, but you can give. But anyways, I'll tell you, adenosine would not do anything. So, so then. The teaching point of this ECG, and when you see this ECG, you should say it's VT, okay? Until proven otherwise, of course. And then if you give adenosine, nothing happens. That's again pro VT, and against SVT with when you have SVT, it's either with white QRS, it's either SVT with aberrancy or antidromic SVT, meaning going down an accessory pathway and up the AV node. So either antidromic SVT or aberrancy, you get white QRS, okay? Or if you have someone with a intrinsic, right bundle branch block and he's in SVT, you get white QRS. So, this is the scenarios where in SVT you have white QRS, either aberrancy, either someone with intrinsic bundle branch disease or antidromic SVT, okay? So you give adenosine, because if this was antidromic SVT, adenosine would, of course, stop it. If this was aberrant SVT, adenosine would stop it. Okay. If it's VT, of course, it will not stop it, okay? Okay, so we gave adenosine and nothing, doesn't do anything. So again, definite, almost definite VT. The point is, the point that you need to recognize when you have a definite VT and left axis deviation with right bundle. Have you heard of fascicular VT? It's a very, I don't know whether our people heard of it. It's a
in adult they say, and this is the one which responds to the verapamil, isn't so?
Right, Belhassen, yes. So yeah, you see it in adult, and this is our patient, Babu. So you see it not in adults, you see it in pediatric as well. You see roughly a case a year, roughly, So we have, in fact, we have two patients. Well, we have this is definite one, and we have another, another similar one. But in general, you see one or two cases, one case a year or one case every 2 years. So you see this, okay? So it's called, so just not to confuse people, it's called posterior fascicular Vt. It's very benignish, VT, happens in healthy people, whether young adults or pediatrics. And it's the teaching point here is very sensitive to verapamil, okay? So I think Ali or I don't remember who, I told them start verapamil, okay? Well, when they called me, someone had already given amio, okay? Again, because I wasn't in Kuwait, so, anyways, they gave amio. So again, I'm just saying here, white QRS, no clear P waves, we said all this. Okay, so they gave amio, and then they called me immediately after the giving amio. People were worried, white complex, people get nervous, and he was very stable. But anyways, so I told them give verapamil. So they, the text, I just checked yesterday because, I was curious as well. So I got the text at 6:13 or 6:12 a.m. Okay, and I told him, give verapamil at 6:14 a.m. Okay, and he texted me. I don't think it was Ali. I think it was Ismail, actually, Ahmed Ismail. And then at 6:54 a.m. he texted me. He said, he texted me this ECG. Okay, so again, I'm sure when I told him give a verapamil, people need 10-15 minutes to give it, at least. So I don't know exactly when did they give it, but definitely, after 6:14 a.m. and, so it's probably more towards 6:30, and then immediate, almost immediate termination. Okay. So this is a very,
with the first degree heart block. Huh?
Yeah. So, yeah. So then what was annoying me that he had, very, very obvious first degree AV block, and he also has, you know, right bundle that normalized, you know, in afterwards. But he definitely had, you know, conduction delays, whether it's amnio related or verapamil related, I'm not sure. Verapamil dose was low, so I'm not very sure whether it's amnio and verapamil both at the same time maybe did this, I don't know. But because of this, I gave him sotalol after, you know, his conduction improved, and he, you know, on sotalol, you know, things are good with normal PR and no right bundle. You know, sotalol is not, it's not the typical drug of choice, but I gave him sotalol because I was worried that verapamil is, for some reason, he did not like verapamil in terms of conduction. Of course.
So the verapamil is a drug of choice, huh?
Yeah, in this case, you know, I mean, ideally you should give him verapamil.
One question, Mohammed. Do you give verapamil less than 1 year of age? Some books say it's contraindicated.
No, you don't. He's 3.5 years old of age. Yeah, you don't.
Okay. Generally.
Yeah. So it doesn't usually happen at this age. Usually happens, you need because it's a you know, it's a macro reentrant tachycardia. You need you cannot have it in small hearts. You need a bigger heart, you know.
So this is a macro reentrant.
Yeah, it's a macro. I'll explain the circuit in a minute. It's a, you know, yeah, it's a circuit. Okay, it's not a focus. It's a circuit. Okay, reentry. So it's regular. Usually starts and, you know, starts suddenly, terminates suddenly, and with the fixed heart rate, with fixed rates. Okay. Okay.
Mohammed, why is the right bundle branch? It looks like a left because it is low. It is negative in V1.
No, so right bundle, you know, you with right bundle branch block, the definition of right bundle is you have delayed terminal conduction. Okay. So in this case, you have R, you know, you have R prime. Okay, you have R, you know, wide, ugly R prime. This is, you know, delayed late ventricular activation, which is right bundle branch block. Okay.
Okay.
Okay. Okay. You know, it's like not, you know, it's maybe incomplete, right? It's not super wide. I didn't, you know, I don't know how many. It's not super wide. By definition, it's not right bundle branch block. It's just right bundle branch delay, you know. Okay?
Yeah, we'll call it incomplete RBBB.
Yeah, you can call it
incomplete. Yes.
Yeah,
but during tachycardia, it was RBBB pattern, isn't so?
Yes, yes, it was. It's a must. And with fascicular VT, they always have right bundle and left axis deviation. Okay. With posterior fascicular Vt, which is the commonest fascicular Vt. Okay.
Okay.
So I gave him sotalol just because of this worry, and he did well on. It was a trial, and sotalol worked well for him. And I think there are reports of sotalol being fine for this VT. It's of course not the drug of choice. And I saw him once he had a Holter one day, and Holter was very good. But then he disappeared. I did not see him for a while. I don't know why. I hope he's still taking his drugs, but you know, anyways, but on sotalol definitely things are good, was good. Okay. So verapamil, like you said, you know, Dr. Babu, you know, it's definitely contraindicated in infants. Okay. You know, and you know, something, you know, like if you have decreased function, again, you know, with WW, you cannot give it usually. The dose is, you know, we don't give verapamil so much. That's why I wrote the dose here.
What is that worse than MG and DMD? What is that?
This is, you know, myasthenia and Duchenne. They don't, you know, muscle disease, they need calcium, you know, so you cannot give them.
Okay.
Yeah. So of course, you know, we don't have muscle disease usually in our patients, but, you know, just keep this in mind. You know, I know I have one patient with multiple sclerosis in the WW, but I don't think I have myasthenia gravis and, you know, arrhythmias. They rarely have arrhythmias.
Why is it contraindicated in muscle disease?
Yeah, I mean, calcium for, you know, muscle contraction, right? So, I mean, you know, they want the calcium for muscle contraction, and you know, it definitely weakens them. And then, of course, they get pulmonary, you know, dependency and risk of intubation and stuff. You know.
Yeah, yeah. Mm-hmm.
Okay. Okay. So, anyways, the problem with verapamil is TDS. Usually, every 8 hours, there is a sustained release form, which is you can give BD or, you know, sometimes even once a day. There's extended release, which is once a day. We don't have it in Kuwait. I don't know whether Saudi Arabia you guys have it, but
which one?
There's extended release. There's immediate release, sustained release and extended release. Extended release.
Yeah, we have both. In adult side, we have got both.
Yeah, you don't have extended, you have sustained release, which is BD. Sometimes you guys give it as an OD once a day.
Yeah.
But you know, typically it should be given twice a day. And the usual pediatric, you know, verapamil is usually TDS, okay? We usually give immediately.
Yeah, in adult also they give 3 times a day. 43 times a day we start generally.
So this is the immediate release. So which is annoying, you know, no one gives, you know, I have this, you know, when I was traveling just last summer and my son had, you know, finger infection and we went to this clinic and they gave us penicillin and it was Q6,
Oh.
you know, and I did not realize, you know, I just took the prescription and went home and, you know, anyways, and then I was unable to give him Q6. It's ridiculous, you know, like you have to wake him up in the middle of the night to give him drugs. And then, you know, so it really was a frustrating. I never was able to give him Q6. I gave him eventually Q8, you know. So, you know, in babies Q6 is fine because they are breastfed every 2 hours. But, you know, once people sleep during the night, you cannot, you know, Q8, Q6 gets very difficult, okay? So that's why I don't like to use verapamil so much, and the compliance would be very poor, okay? So that's why I avoid it, and I only give it for, you know, fascicular VT, or, you know, if nothing works, you know, you can try it for regular SVTs, but usually, you know, it's annoying. This TDS is very annoying, okay? Okay? There is a risk of hypotension with IV, so, you know, make sure you have calcium chloride, you know, at bedside, especially for babies. And, you know, it's like there is liver kidney adjustments if you need to, but, you know, of course, we typically don't give verapamil if you have renal or liver disease. Anyway, so this is the posterior fascicular VT. It's usually benign. So the circuit is here. So you see if you see my hand is like the ventricular septum. It's like going around the ventricular septum. Okay. So imagine this is the left side of the LV. It's going, you know, like it's going around the left side of the septum and going like from the superior part and, you know, going down the posterior fascicle, superior, and then superior edge of the septum to involving the posterior fascicle. So there's a circuit in the septum, okay? So, you know, the circuit goes like this, okay? And so that's why, you know, it's a macro reentry and you know, it's sudden onset, sudden offset, regular rate, okay? So it behaves like reentry, okay? Reentry, okay? Anyway, so that's the circuit. There are other types, but this is the most common fascicular type, okay? So I'll just, I will not, you know, it's the other types are very rare, so I wouldn't worry about them. Okay, so this is the other child that I told you, you know, this is a child that I inherited from my, you know, when I came in. He is now 7 or 8 years old. He had normal heart and he was ablated twice before my time in Kuwait here, but, you know, failed ablation. And this was his tachycardia. Again, you know, similar, huh? Like left axis deviation, right? And right bundle, right? You guys, okay? You know, you know, AVR is
Yes.
like, you know, AVR is, it's probably positive, but it's more equiphasic. But, you know, so people, you know, there was one, you know, one very famous electrophysiologist who was a visitor here in Kuwait, and he ablated him. But the child was 4 years of age, so he was very small. And unfortunately, it came back. And then another electrophysiologist tried, and it came back. So, you know, it keeps.
Mohammed, one question, please.
Yeah.
Will you say this is a WPW because a short PR and delta V in V1?
Well, again, so where do you think the P are? You know, where do you think there are P waves? Like, can you convince yourself where do you see P waves? You know, I don't, you know.
The P wave is a sharp one, then the delta wave comes immediately from the terminal part of the P wave.
This is all QRS. You mean, which lead are you looking at?
I'm looking at V1.
V1. So this is, you mean this? This is QRS still.
The black one. No, black one. Black one. The black ECG. If you look at V1.
Yeah, I'm
V1
in V1.
or
Yeah.
It's a view of the last part of that.
Yeah, this
the
is
last part of. No, go further to the right. Go further to the right. Yeah. Don't you
Before.
think that part is short PR and delta wave?
No, this is the T wave, huh? Not a P. This is a T.
But it's a sharp wave.
Yeah, it's it's a biphasic. So the question is this: it's a biphasic, wave. Whether this initial deflection is a P and then followed by a T, I don't know, or this is all a T, I don't know. It's difficult to convince yourself.
I would have thought it's a delta, short PR delta wave.
It's very fast. He's coming. He's 7 years old. He's coming in clinic doing nothing, and his heart rate is like 160, 170. So it's not sinus. Okay.
This is 160.
Why does he have sinus tachycardia? Okay. So he's relaxed. He's not in pain. He's not having fever. He's not anemic, and he's very 170, 180. So it's not sinus. Well, that's a hint. Okay. And lead one, typically P waves, you see them best, lead 1, 2, 3 AVF. It's difficult to see. You can see deflections. You wonder whether. But look at lead 1. There is almost nothing convincing. There's a P before the QRS. Okay.
Do you think there's a lead 2, lead 3 AVF looks like a Q wave?
Well, yeah, it's a VT, so it's all Q waves. But it's the Q wave during tachycardia is not an infarction sign. It's just because it's coming from the side. Okay. So so this in this case, so again, similar to the last case, it's definitely wider and uglier looking QRS than before. So I showed you this because he's one of our patients, and then at some point he does this where he has sinus, and Babu here, by the way, this is usual P wave looking in lead 1. So you don't see it here in the black, So again, this is another hint. This is his P wave. Oh, you see his T wave.
But the red one is.
You see his T wave in V4.
It's a different QRS, isn't it, sir?
No. There is a bigeminy here. Okay. You see
this is bigeminy, no? This is after the EP study, no? The ablation.
Well, no, he was on drugs. So when he's on drugs, it's improved. Okay.
But the V1, if you look, it's a totally different morphology than the upper one you have shown us, isn't it?
Yeah. Well, remember V1 is very lead position, dependent. Meaning, V1, it's fourth intercostal space on the right side of the chest. How many times you had seen nurses placing an ECG and counting number of intercostal space? 0, never, right? So V1 is very poorly positioned in general, okay? V5, V6, V4 is less poorly positioned because they usually, they aim for the nipple and then they go around the nipple, right? So it's more, not nursing dependent, but V1 is very poorly positioned. That's why you get variation in V1 morphologies very often, okay? So never be, swearing on V1 being different or not. V1 is very tricky, position dependent, lead, okay? So usually nurses place it just wherever, right? They don't count, okay? Okay, so, and Babu, V4 here, you see that his T wave, you see it's biphasic. So
where?
In V4 here, you see the T wave, his usual T wave with PVC.
V4.
You see it here, you see me?
Yeah.
Similar to the black thing, right? The black ECG. So that's the T wave for him. Okay, anyways, so he does this, with treatment, he does this. So the point of this, ECG was, again, when you have left axis deviation, right bundle branch block, you could have posterior fascicular Vt, but you could have something else. You could have an automatic focus from the left ventricle that is not verapamil sensitive and is more difficult to ablate. It's more difficult to manage, less likely responsive to drugs, and he's one of those. Okay, so he is not fascicular VT, he's LV papillary muscle VT, which is more difficult to treat. That's why people struggle to ablate him, and now I'm giving him drugs. Things are good on drugs, but at some point, you need to re-ablate him. So he's at the age where we should consider re-ablating him, okay? But he already had two procedures before and they failed. So of course, family is, not very excited about re-ablating third time, and with roughly 60-70% success rate. Okay?
So when we ablated, what did they think? They also thought it's a VT?
Well, yeah.
Electro EP study?
Yeah, there's no question it's VT. They all know it's VT. The question, where is it coming from?
Okay.
It's coming from, they just missed, they burned not exactly at the spot, so they were, they were off in terms of where to burn. They both tried, they both burned, and they both had acute success in the EP lab, but it comes back, meaning they were off, okay? Meaning
so Muhammad, because of the left side, he's a left axis VT. So is it obvious from the beginning that the EB will be unsuccessful because the left side?
Difficult. I'm sure they told the parents is roughly 70%. When it's SVT, you tell the parents 90% success rate. When it's VT, you tell them 60, 70%, 80% in best hands, 85%. So it's definitely lower. Okay, and remember he was 4 years old only, so I don't know what was his weight, but he was very small. Okay, so you don't, they improved things, but he's still requiring drugs and stuff. Okay. Okay, and they were done by two very famous electrophysiologists. So, and at in a difficult VT, difficult age, things happen, and this is a good example of it. Okay. Okay, so the point of this ECG is that not all the time when you give, occasionally verapamil would work, but sometimes would not work, like in this scenario. It's difficult to tell sometimes. You try verapamil, if it doesn't work, it's not fascicular VT, it's something else. It's a VT coming from the left ventricle still, but not your typical fascicular VT. And when you see PVCs by Gemini, it's not re-entry, because remember, re-entry is usually steady. When it goes off, right? When you get one beat of tachycardia here and there, this is automatic. And, so again, this points against fascicular VT. Okay, so these are both our patients. So people, it's not like from the internet. These are all our patients that we deal with them. So you see these patients all the time, once a year, not very frequent, but you will see them if you practice cardiology long enough. You will see in your career 1 or 2 cases, every couple of years. Okay, so you have to be aware of such diseases. Okay, of such arrhythmias. Okay, not everything is SVT. Okay. Okay.
Now, thank you, Muhammad. Excuse me.
Question, Muhammad.
Yeah.
In the red ECG, if you look at the AVR and AVF, there's a P wave and QRS. Then there is a negative one. It's a T wave, the negative part, or that's an above. Yeah, that's a T wave.
Yeah, that's a negative T wave. Yeah.
P wave?
No. So this is the P wave, right?
Okay.
QRS, and then a T. The T is a little bit negative. Whether it's of course not normal for a T wave to be negative, but this is, remember, he's on drugs, he's on flecainide, and I don't know whether this ECG was taken immediately after, immediately after EP study, I don't remember.
Okay.
So, but the T wave, of course, is not normal for him. But he has
and the next one is the ventricular beat, isn't it? So VPC.
This is the tachycardia, but he's not just, it's not non-sustaining.
This is bigeminal.
Yeah. He has so much PVCs, but on drugs, of course, off drugs, he does this. He has incessant tachycardia. So for him, the goal is to make sure he's controlled on drugs until people are comfortable ablating him, trying a third attempt. Okay. And family are open to a third attempt, but they are not, they're not jumping. They are happy he's doing well on drugs, so there is a time to wait. There's no rush. Okay. We're 10, we are, so we're towards the end. So again, this is not our patient. This is, we did not have such a patient yet, but this is an ECG that people should know, because again, it's very important. Yes. So what is this?
Pretty excited AF.
Right. So this is AF with WW. Okay.
Yeah.
It's very classical, and people should be aware of it, because this is how WW patients die. Okay.
Yeah.
So you have to, obviously it's very, very fast. Usually, 300 plus. At times.
Rare in children, isn't so?
Teenagers, you see them. I saw 2 cases in teenagers. I saw, In the US and Canada, I saw 2 cases. In Kuwait, I did not see yet, but I saw 2 cases in Canada and US. So you see them, but they are teenagers, usually 13, 14 years of age, okay? So you see them, of course, not in babies. And then, you know, it's AFib because it's irregular. And then, you know, you get a hence, you know, you get a delta, you know, a sense of a delta wave, you know, when you see such an ECG, it's irregular and wide QRS, you have 2 differentials, main 2 differentials, either polymorphic VT or AFib with pre-excitation, okay? So, you know,
no, only it's a rate also, more than around 300 rate. Normal AF will not have that rate.
Yeah, because of the accessory pathway. So, you know, you have 2 differential. You may not be very sure which one is, you know, this patient is having which one of those. The point of this ECG is to be aware of something called AFib in WW, and be aware that when you see such an ECG and you're not very sure, don't give adenosine, because this is where it's contraindicated. Because when you give adenosine, you promote accessory pathway conduction and you promote VFib, okay? And you know, so if you're not very sure and you don't have an EP person by your side, cardiovert them, because you're not sure. VT, you'll be fine. If it's AFib with there, you'll be fine either way, okay? You can cardiovert them. But if you are sure it's not, if the patient is awake, and my 2 patients that I told you about, they were both awake despite very fast, you know, they tolerated, you know, if it's supraventricular tachycardia, usually people tolerate them very well. I mean, they are usually borderline blood pressures, very drowsy, but they are awake. So you can try drugs if you think it's not VT, because polymorphic VT, usually people don't tolerate, you know, VT at this age, at this rate. So, you know, when someone is awake and speaking with you with such an ugly ECG, you may lean more towards with AFib. And of course, polymorphic VT is unusual for a normal, healthy, you know, healthy teenagers. Anyways, so, you know, the drug of choice, like, you know, fascicular VT, we said Veratrol is the drug of choice. In this case, you want to give, you know, drug of choice procainamide, okay? We don't have it in Kuwait. I don't know whether folks in Saudi Arabia, they do have it. We don't. So unfortunately, if we had such a case, we have to cardiovert. You know, people sometimes can try flecainide, IV or PO, but you know, it's you know, it takes a while for flecainide to work. So if you give PO flecainide, you will need to wait for 2 hours roughly. If you give IV flecainide, then it's, you know, it's more quick. But you know, our IV flecainide is, you know, we do have IV flecainide. I did not have IV flecainide when I was in the US and Canada, so I do not have so much experience with IV flecainide, but we have it in Kuwait actually, and I'm using it for Brugada rollout. So you know, IV procainamide is very safe. IV flecainide is, you know, I don't have that experience with, and in general, people are more comfortable with IV procainamide than IV flecainide. So if we get a patient, we can do IV flecainide, but cardioversion, you know, plan B and at bedside, or just cardiovert him directly. We'll see when it comes. We'll see, but we will see such a patient one day. You know, it happens. You know. Anyway, so this is what, you know, you need to be aware of. You know, and you know, if you're not sure, DC them, and don't give adenosine. If you see something irregular, wide, don't give adenosine. Even if you say, I want to see what happens. In this case, you cannot do this. Okay. Okay.
Any doubts? Better to give DC shock, huh?
Yeah. I don't like to give DC shock. I mean, you probably know by now. I don't like to give DC shock unnecessarily, but you know, sometimes if you have to, you have to. Okay. And you know, one last ECG before we quit. Of course, if you see such an ECG, this is a neonatal. You know, I gave you the diagnosis here. You know, this is a patient who had VT in utero. He had 2 fetal echoes, both were in VT. So people started flecainide, and then, you know, he developed hydrops, so he was, you know, induced. And when he was born, you know, to our surprise, he was in 2-to-1 conduction. And then, but soon afterwards, you know, he developed such a rhythm. It's ugly. It's very wide. He was unresponsive, asystolic during this because he had an arterial line at the time. And so, you know, this is when you see something very ugly, very wide, and this is, remember, this is only a couple of hours old. This is definitely there's not SVT with aberrancy. He went asystolic, he's unresponsive, you shocked them, of course. And then if you look very carefully in retrospect, you probably see AV dissociation as well, probably.
Yeah, you can see,
yeah, but it's very ugly QRS. This is never aberrancy QRS, okay? It's very ugly, very wide, very
wide.
Yeah, okay. Anyways, so this patient, long story short, we gave him lidocaine to suppress the VT, but we did not start lidocaine because baseline is 2-to-1 conduction. So we had to give him pacemaker and then give him lidocaine and then transition him to amio and beta blocker. And with the pacemaker, he also has cardiomyopathy, but function is decent, like borderline, but decent. But, myocardium is, echogenic and well looking or normal looking. So anyways, he probably needs genetic testing, but in the meantime, we think it's all mom. We wanted to test mom for for lupus antibodies, but she never went. So whether it's all lupus, cardiomyopathy with AV disease and VT, or some genetic disease, there's no family history of any genetic disease that required arrhythmias, pacemaker, ICD, and stuff. But anyways, he, of course, he's at home now. He's doing well. I mean, the question is whether he needs, ICD or not. He's a baby, so ICD is very, very unusual, difficult to implant at this age. So he's not an ICD, but I'm worried about him. But hopefully on amio and beta blocker and pacing and stuff, things would settle down. But anyways, that's an interesting case. This is only a couple of months old, 6 months, 4 months old.
This 2:1 is different ECGs, and so?
Yeah, different. I did not, I was, okay. The theme of today was, VT, because we did not talk about VT. People wanted SVT, but I was gonna, VT is more interesting. SVT, we talked about.
Yeah. Unless you get a classical broad QRS, people will not think of. The first VC show probably people think it's a supraventricular.
Yeah, so I intended to talk about SVT again today, to be honest, but then I saw these VT ECGs and I changed my mind. Sorry, Nasser specifically wanted SVT, but I think he meant ECG in general. I don't think he meant SVT. Anyways, so so he have white, lastly, if you have white QRS, it's VT until proven otherwise. I mean, I don't know. This statement is not very accurate, to be honest. This statement is more for adults, but ignore this statement a little bit. This is from the internet, not from me. So anyways, your differential is SVT with aberrancy or antidromic re-entry tachycardia or AFib with pre-excitation. Okay. So we showed, couple of other VTs and stuff. So, SVT with aberrancy, you have typical right bundle or typical left bundle, and typical, if you have right bundle branch block with aberrancy, you usually have right axis deviation or normal axis deviation. If you have left bundle branch block, you usually have left axis deviation usually. So if you don't see such normal combination and you have a normal heart, then think otherwise, okay? Antidromic SVT is tricky because it's difficult because, according to where's the pathway, you get different morphology QRS. And this is where you cannot tell for sure, often you cannot tell for sure whether it's VT or antidromic SVT without adenosine, okay? So this is where people get confused, whether it's antidromic SVT or VT. Adenosine, solves the issue usually. But otherwise, aberrancy, you should be able to tell whether it's aberrancy or VT, okay? And we're done. Questions? Everyone is muted, so I'm not expecting, I don't know, people have been very quiet today. But remember, with ECGs, people has to say, people need to speak up because then, I don't know whether you guys are following or not.
Dr. Muhammad, how are you? This is Khaled.
Yes.
I would just like to ask about the dosage for the Ficanol we have to give, and how many joules, the dosage.
Of what?
Flecainone.
Yeah, so flecainide dose is, you're talking, of course, in adults it's in pediatrics, it's per kilo. Khalid, by the way, Khalid is a medical engineer in our lab. Khalid, it depends on the weight. So you usually use per kilo or per meter squared. Per kilo is easier, but often people, per meter squared is more accurate. But anyways, per kilo is around 2 to 3 per kilo per day starting dose, and then you can go up to 5 per kilo per day, and then divided PD or TID depending on the age. Okay, and DC shock, 0.5 per kilo if it's atrial tachycardia AFib, and VT 1 per kilo or more. Okay.
Okay, thank you very much.
Anyone else?
Doctor?
Yes.
Thank you for the nice lecture. I would like to ask about this patient who received flecainide. He have high drops. Is it the best option with the high drops and will absorb easily, or there is a better option for such case if patient with
well, they once he developed high drops, they induced him. So before flecainide, he did not have high drops. Okay. He when they did the fetal echo, he had VT, but without high drops. So they started the flecainide. The repeat fetal echo a couple of days afterwards, he was in VT with high drops, and then they induced him. Make sense?
Yes, thank you.
Welcome.
Thank you, Mohammed.
Welcome.
Happy Eid once again.
Okay, anyone else? Questions?
مشكور دكتور محمد يعطيك العافية.
الله يعافيك. Okay, thank you.
شكرا دكتور محمد، شكرا. كل سنة وحضرتك طيب. كل سنة وجميع إخوة طيبين.
مشكور. مع السلامة.
Thank you for your time and dedication, doctor. Thank you very much.
Thank you. Bye.